Dr. Daniel Griffin.
And I'm Dixon Dupamier.
And today we're going to be discussing pneumonia.
Right.
Lower respiratory tract infections.
My goodness. Serious stuff.
You know, it is, and it's amazing to me, but here we are, and pneumonia continues to be one of the top 10 causes of death throughout the world.
Absolutely.
So it's amazing that it is still so common.
Yes.
There might be reasons why it's so common, but proper management of pneumonia can reduce the mortality by as much as 70%.
Really?
So this is a critical situation where proper diagnosis can allow you to make a big difference, and proper diagnosis and management can again limit inappropriate antibiotic prescribing.
Right.
So hopefully today we're going to all get a little bit of a handle on how to work through what is a challenging and critical problem.
Sure.
So one of the things that I'm going to start by saying is that it's really important to distinguish bacterial pneumonia that would benefit from antibiotics from upper respiratory infections, predominantly viral, where antibiotics not only are inappropriate but associated with harm and resistance development. Have you ever had pneumonia, Dixon?
I have not, but my father did.
Okay.
And I remember when he became ill, it was in the middle of the summer. It didn't seem like such a great time to catch anything that was had something to do with an infectious disease. Summertime is thought of as everybody's out and they're living healthy lifestyles and going fishing or swimming or boating or whatever. And my father was laid up in bed with pneumonia for about a week and a half. Turned out that, of course, he was a heavy smoker. So might have had a complicating factor associated with that. Mm-hmm. And no one else in our family ever got it. And my father was a young man when he got it. He was in his late 40s when he became ill. So it was not an older person infection at that point. And I had personal experience with it. I didn't know enough to be concerned about it until the doctor made the third house call. In the days when doctors used to bring their little black bags and sit down next to the patients. And after that, everyone in our family became really worried about his ability to recover from such an awful disease.
Yeah.
He did, of course, but a lot of people don't.
Well, I think you bring up several great points. I don't know how you do this, but you have the ability to spin an anecdote with hitting all of it. So one, and I think this is sometimes people have the idea that pneumonia is the old man's friend. I think that's an expression. They believe that pneumonia is something you get when you're older. But as you describe, and within the last year, my wife, who is a healthy woman in her 40s, ended up with pneumonia.
I'll be darned.
A colleague of mine took care of her, but she was quite ill.
Goodness.
So pneumonia does not discriminate. Pneumonia, all takers. So that's one thing, is pneumonia may be common in different age groups, more common in different age groups, but we see pneumonia from infants all the way up.
Wow.
So that's one. It can affect all ages. And we're going to talk about how we diagnose it in an age-specific manner. Right. The second is we see pneumonia all throughout the year, but we see different seasonal frequencies for different types of pneumonia. We just finished our Legionella season here in the New York area. And Legionella is something we see quite a bit early in the spring when people turn on their air conditioners after they've been sitting over the winter.
Tell everybody what the name of the organism is.
Well, Legionella pneumophilia.
Pneumophilia, that's right. Yeah. So
because it loves the lungs.
I was at Columbia as a young faculty member when the original outbreak at the Mayflower Hotel in Philadelphia occurred. And no one knew what it was at that point. And I knew one of the I guess they were called epidemiology investigative.
The EIS.
EIS.
Epidemiology
I knew someone who was
Service.
sent to that hotel, and he shared with us how trepidatious he was to go because no one knew what was happening, and it was among a group of American war veterans, and so it was sometime it was called Legionella's disease. Because of
the American Legion members.
That's exactly right.
Exactly
right. And to have it full blown now in terms of its epidemiology, and we even had some it's a hospital-acquired infection now, I understand also.
So it can be. It can be. It can be in the water. So that's why we see a seasonality to it. We also have. We talked about bacterial, but we also have viral pneumonias that we see at certain increased rates in the winters. We often see bacterial pneumonias that follow those viruses. So as you mentioned, the winter we tend to see more pneumonias, both viral and bacterial. So there is a seasonality. Certain infectious pneumonias such as mycoplasma might cluster when we have, say, schools, military recruits. So there's a seasonal variation to certain pneumonia. So it doesn't care about age, but there is a seasonal variation to different types of pneumonia.
And the old term for that is infectious catarrh. I loved it. I knew someone who worked on the organism at Rockefeller, and John Nelson, and he says, this is infectious catarrh, and this is, those are the old world terms for these newly discovered infections, which are now commonplace. So what's walking pneumonia?
So it's interesting. You brought up the comment before in your story that you didn't know enough to be concerned about your father.
I didn't. No.
And there are clearly various severities of pneumonia. And it used to be that walking pneumonia was a reference to mycoplasma pneumonia, an often less severe pneumonia where people were not completely debilitated, they were not in the hospital. They might be able to be treated as an outpatient. And we certainly still have less severe cases of pneumonia where people do not require hospitalization. And we'll be talking about how to triage, so to speak, later on. Because some people will be severe enough that they benefit from being in a hospital, they benefit from intravenous versus oral antibiotics. So we're going to be we talked initially about the distinction between viral and bacterial, but more so pneumonia versus an upper respiratory infection. We're going to want to be able to figure out how do we make that distinction. And then something as a healthcare provider is really critical. You want to make a distinction between all these lung issues and pulmonary tuberculosis. And a criteria that people will use is a duration. If someone comes to see you and they say, I've been having a cough and difficulty breathing for more than 2 or 3 weeks, a lot of countries use a 2-week duration, then you start worrying about tuberculosis. And you might rule out tuberculosis before you let them hang out in the waiting room with all the other patients. So this is when we talked about how a clinic might be set up where you have an intake person who is, what is your name? Why are you here? And if you say, I've had a cough, it would be great as early as that, but how long has this cough been going on? If they say for more than 2 weeks, that might be enough to fast track them so that they're not sitting there with your young mothers, with your children, with your at-risk vulnerable populations.
Would you ask also whether they were coughing up any blood?
The 2 weeks is a good enough distinguisher. Later on, once they get to the clinician, you might start asking more questions about weight loss and blood. But you want to be really sensitive because you don't want to accidentally have someone with tuberculosis sitting there in your waiting room for whatever length of period of time it takes, filling the area with the tubercular bacilli. But how do we make this distinction? They come in and they tell you, I've been coughing, I have a fever maybe, I don't feel well. How do you know if it's pneumonia or not? And I sort of ask you your thoughts.
Well,
you've been to the doctor, right? What do they do?
No, I've had lots of upper respiratory infections, as a matter of fact. I used to get something called bronchitis. And the bronchitis was associated with stress. I know this because I used to get it around the time that I was applying to graduate school. I got it after I finished graduate school and took my first job, which was not at Columbia University, but somewhere else. It was a stress-related deal, and it wasn't caused by any particular organism, I don't think, although in both cases that I can recall, they recommended antibiotics, and of course it got better. But it got better because the stress disappeared, I think. And I became, more used to where I was and more acclimated, and things began to come. So I don't think I've ever had viral pneumonia. I don't think I have, but I've had some prolonged infections in my life.
Well, the distinction that we're trying to make between pneumonia, and you joked about pneumonia versus old pneumonia.
No.
So the pneumonia is airspace disease. So it's a lower infection that actually involves the airspace versus upper respiratory infections, which might be your rhinitis, your bronchitis. Right. In those situations, we rarely recommend antibiotics.
Right.
So I know your doctors may have given you some antibiotics, but I'm going to frown on that.
I would too, but I certainly would. And you know, you start coughing up this colored phlegm of mucus, and you know, it goes from a bright green color to a yellow, and it changes characteristics of whether it's stringy or whether it's loose, whether it comes up regularly or whether you really have to work at it to get it to release. And there was something that went around our floor of the Department of Microbiology not too long ago where everybody on the floor complained of this same thing, including the former chairman of our department, and everybody came down with it, and you couldn't shake this thing for months. And we had no idea what it was, and no one tried to culture it, of course.
So it's helpful when you can actually identify.
So you can either culture it or you can x-ray the patient and ask whether or not it's got a lumbar portion of...
So that's good. So let's talk about how do you make a diagnosis of airspace disease? So, you know, some people would say the gold standard would be
breathe into a tube and see how far it goes up.
Would be a chest X-ray.
Yeah.
Right. So you do either a chest X-ray or in some areas with maybe too many resources that they might do a CAT scan.
That's right. That's right. Exactly.
So you're sort of visualizing with radiographic testing that there's infection in the air spaces.
Yeah.
An experienced clinician may listen, and there's certain physical exam findings where you can hear areas of decreased breath sounds. Maybe it's, we'll use things like egophony, E to A changes, which a solid consolidated airspace will. So there's, we'll call sophisticated, experienced clinicians have the ability fairly reliably to recognize airspace disease.
Right.
But the WHO has realized that that's actually a fairly rare skill. Most clinicians cannot reliably listen to a chest and determine whether or not someone has airspace disease or not. So they've actually recommended what they call fast breathing pulmonary infections. And the fast breathing infections, and we have a table, so those of you watching this will see this. But let me run through this a little bit because this is interesting.
Please.
And this was something I learned again when I started practicing outside the United States, is that I was practicing with some, I think, fairly skilled senior clinicians from England. And they had the ability to really, and you know, I would listen as well, and they were very good about being able to identify airspace on exam. But a lot of our patients were being seen by, I'll say, trained nurses. And I would say the WHO has recognized that that might be an unrealistic expectation that all the clinicians with a stethoscope can recognize airspace or not. And so the fast breathing criteria that they've introduced is a much more reliable way of determining who does better with the antibiotics and who can do better without antibiotics. Maybe they need to come back, that's possible. And so we have a whole chart, and again, it's age-based, because what is a normal respiratory rate changes with age.
Right.
And so we start off with less than 2 months of age. Normal respiratory rate is 35 to 55 breaths a minute. It's really fast.
No, it's like a hummingbird.
Where you don't really drop down to the 12 to 16 until you're about 12 years old.
Right.
And so in a 0 to 2 months, if it's above 50, in a 2 to 12 months, it's above 60, 0 to 2. 2 to 12 months, it's greater than 50. 2 to 5 years, it's greater than 40. 5 to 12 years, it's greater than 30. And then that's what we'll sort of carry forward.
As the lungs grow and as the body's demands go up,
you're actually
volume increases,
and
you're making up for that. So this is at rest. We see a lot of case histories that start off, the patient was admitted with a primary complaint of shortness of breath.
Yes.
So what does that mean?
Well, so I think that's...
excuse me.
Yeah. You cough away. How long have you had that cough? This is, again, one of the great situations where the people who are checking in your patients can almost be making the diagnosis ahead of time. The person comes in and says, I've had a cough, and there's going to be a triage. Has this been more or less than 2 weeks? More than 2 weeks, you want to go and get them tested for tuberculosis right away if you're in an endemic area. If it's less than 2 weeks, then you want to say, let's send you to the vital signs and have them check how fast are they breathing relative to age. You might also look at the heart rate. Is the heart rate accelerated relative to age? And at this point, they can come to the clinician with I have trouble breathing. I feel like I'm working harder than I'm used to breathe, and my rate is putting me in the fast breathing. And then you've got to ask yourself, how much do I trust my clinical exam? And do I have the ability to get imaging to help me here? If someone comes in and let's say they're 11 years old, they're breathing 40 times a minute, they don't have a history of asthma, then you want to start thinking about, am I going to go with the diagnosis of pneumonia and consider treatment? Right. What you'll notice is not in my chart is the color of the phlegm. And so I'm going to ask you this question, it's really for the audience, but what makes sputum, what makes phlegm green?
Green?
What makes it green? Like people come in and they say, I was going along, I was having trouble breathing, but then it became green, and the clinician said, oh, now you need an antibiotic because are bacteria green?
No.
No. What color are bacteria?
Well, they vary in color, but they're not green, I can tell you that.
So they usually don't have much color, which is why we need to stain them.
Well, Staph aureus has color.
Well, in culture, what is the aureus? It's the yellow that grows in culture.
Of course.
But most of the bacteria in sputum, you're not going to see.
Right.
You're
So
not
the
going to
green.
So the green is coming from our white cells. It's actually myeloperoxidase and neutrophils. So all this means is that you have inflammation. You could breathe in smoke, it'll turn your sputum green.
I like
you
that.
could have a viral infection, it'll
good.
turn your sputum green.
This is good.
So green doesn't mean they need antibiotics.
No.
And I want to dispel that notion. Pneumonia means they need antibiotics. So move your tuberculosis people to the side, diagnose them before they make us all sick. Only give antibiotics to your people who have airspace disease. Use the WHO fast breathing criteria, or if you have the ability to really trust your exam or do imaging. And what about treatment? We have a chart for treatment, and the treatment is going to vary based upon age. But again, we're going to be using a lot of amoxicillin because what is the number one pathogen causing pneumonia in the world? Strep pneumo. So pneumococcus is the number one cause. So your ceftriaxone, your amoxicillin, your penicillin. And again, if someone is weak, if they're malnourished, you want to look at using parenterals. So this might be intramuscular injections or intravenous antibiotics. They may need referral to a higher level of care. They may need oxygen, and they may need supplemental therapies.
What about the causative agent for whooping cough? That's a childhood disease. Without vaccination, that's pretty rampant.
It's becoming more rampant.
It's because people don't want to get vaccinated. This is all true. It's caused by Haemophilus influenza?
No, but
No.
close. Bordetella pertussis.
Oh, I'm sorry, of course.
No, that's okay.
I'm embarrassed.
That's okay, and it's actually the epidemiology of pneumonia will change based upon location and vaccine status. Okay. And in a lot of developed parts of the world, there's been a drop in the amount of pertussis vaccination uptake. So we have started to see more whooping cough, more Bordetella pertussis in the adult population. And I nickname it the 100-year cough when I'm talking about vaccinations. I say, would you like your vaccine, or would you like to be at risk of the 100-day cough that will not go away no matter what we do?
Exactly.
And so yeah, a lot of the changing epidemiology is vaccine related.
Diphtheria is coming back too.
Diphtheria, less pneumonia, more of a throat.
More
but
for
no.
pharyngitis.
No.
That's true. That's true. But still, these things haven't gone away just because we know what they are.
No. Unfortunately, they continue to be very common.
That's so sad.
All right. Other questions before we thank our audience for joining us?
This is a tip of a very large iceberg. I can promise you that. And it would do you well to review. I should have for the causative agent for whooping cough, which I knew, of course, but I just forgot it here. I make the same mistake when I watch Jeopardy on television, by the way, so don't worry about that.
Is that why you missed the grand prize last
Probably,
time?
well, no, there's plenty of reasons for that.
Okay.
But this is a great start to a review, I think.
Yeah.
This is a great start.
And I will, I'll make the recommendation is those not familiar with the World Health Organization fast breathing criteria,
Right.
look into that and really, ask yourself, where are my clinical skills? Where are the skills of the staff I'm working with? And be realistic, because you don't want to miss the diagnosis and you want to use a criteria that is reliable and tested in the field.
Right.
So thank you very much for joining us.
Yep. See you next time.